So now we would like to invite the next speaker. It's Dr. Gao from China, and she will present data from the Childhood Lymphoma Collaboration, and we are happy to listen to her talk.
Good afternoon, colleagues and friends. The title of my speech today is Multicenter Collaboration on Childhood Lymphoma, report from CCCG Lymphoma Study Group. 3 points will be presented in my speech. First, overview of childhood lymphoma. Pediatric lymphoma is the third most frequent cancer type for children younger than 15 years of age, following leukemia and brain tumors. Two predominant subtypes of lymphoma, non-Hodgkin and Hodgkin. According to the data from SIOP Cancer Statistics, the annual incidence of pediatric non-Hodgkin lymphoma or Hodgkin lymphoma is 8.6 per million or 5.5 per million, respectively. Dramatic increase in cure rates of children with cancer is one of the remarkable stories of cancer therapy in the past decades. During this time, the 5-year survival rates for children with cancer has steadily increased and now exceeds 8% in most medical developed countries. With current treatment, cure rates for pediatric non-Hodgkin lymphoma range from 70% to over 90%, even for some disseminated cases. After chemotherapy alone or combined with radiotherapy, the long-term survival rates for pediatric Hodgkin lymphoma is over 95%. Currently, China doesn't have a nationwide cancer registration network. However, Shanghai set up its local cancer registration network in 1973. In 2002, this local registration network extended from urban areas to rural areas of Shanghai. And now it covers all levels of hospitals, community healthcare service, district CDCs, and the Shanghai Municipal CDC. A comparable incidence of pediatric non-Hodgkin lymphoma was detected by the study from Shanghai Cancer Registry. However, pediatric Hodgkin lymphoma seems to be rare in China. The annual incidence is only 0.6 per million, considerably lower than reports from Western countries. Nowadays, China's population is over 1.3 billion, with more than 200 million of children younger than 15 years of age. It is estimated, accordingly, approximately 1,500 new cases was non-Hodgkin lymphoma and 115 new cases with Hodgkin lymphoma was diagnosed each year for children than 15 years of age. Now I will introduce the work organized by CCCG. CCCG is the short term for Chinese Childhood Cancer Group. It was set up in 1997. The main objective of this group is to improve the outcomes of children with cancer in China. Lymphoma Study Group is one of its first subgroup. Besides Lymphoma Study Group, we already have renal tumor, neuroblastoma, liver tumor, and acute lymphocytic leukemia study group. In the future, already in our working plan, we hope we can set up study groups for rhabdomyosarcoma, rare tumor, brain tumor, germ cell tumor, and palliative study group as well. CCCG has conducted 2 consecutive cooperative group trials for children with B-cell lymphoma. The first study, BNH97, was initiated in 1998. It was a modified protocol from National Cancer Institute. 47 patients from 4 pediatric oncology centers enrolled in this study, and its preliminary results were published in 2002. The second study, BNH 2010, was prompted by the impressive improvement achieved in the Western country and was designed to evaluate the feasibility of applying a more intensive short pulse chemotherapy in China. It was launched in 2009. From April 2009 to March 2013, totally 162 patients registered for the study. The 2-year EFS was around 74% for all the patients evaluable for the response. In this study, the EFS was significantly lower for patients with CNS involvement, bone marrow involvement, and whose LDH level higher than 4 times of normal limit. Based on these results, we began our new study for children with B-cell lymphoma last year. In this new study, the dosage of methotrexate and cytarabine were increased a lot compared with previous study. Also, addition of rituximab to the chemotherapy were applied to the patient who has the poorest prognosis in the previous study. 2 consecutive cooperative groups trials for children with lymphoblastic lymphoma have been conducted by CCCG. The first study, LBL 97, was a modified regimen from Memorial Sloan Kettering. 59 patients from 3 pediatric oncology centers enrolled in this study. Physicians in these 3 hospitals published their own data in separate journals. The second lymphoma study, LBL 2010, was a BFM-based regimen. Totally 105 patients from 7 centers registered for the study. The 2-year EFS was 68% in all evaluable patients. In our study, the EFS for patients who achieved complete remission on day 33 of induction have relatively high was higher than those who had not. Based on these results, we began our new study for LBL this year. In this new study, we stratified the patients into 3 groups. Early stage, late stage, and later response group. We enhance PEG asparaginase use for patients in the later response group. Also, we cut off some weeks of maintenance treatment for patients in early stage. Anaplastic large cell lymphoma accounts for 10 to 15% of all pediatric non-Hodgkin lymphoma. I just finished the study last month. 73 patients from 10 centers registered for this study. The treatment was identical to BNH 2010. 2-year EFS was around 63%. This time, I did analysis for patients who suffer from disease progression or relapse. Unfortunately, 2-year overall survival was only 28%. We hope we can begin our new study for ALCL next year. In the new study, we hope we can include a salvage therapy for patients with recurrent disease. Because according to the experience from Western country, for patients with ALCL, even after disease relapse or progression, half of them can be saved with proper salvage therapy. As I mentioned, pediatric Hodgkin disease is rare in China. In our previous study, only 56 patients from 2 pediatric oncology centers in Shanghai enrolled. Actually, HD-98 is a modified CCCG 5942 regimen. We omitted procarbinazine because procarbinazine is unavailable to get in Chinese market. The 4-year EFS and OS were 78% and 88% for all the patients. It was noted in group 2, the EFS rate was higher for patients treated with chemotherapy combined with radiation, but no statistical difference was observed. Probably we omitted the procarbinazine. The EFS for patients in group 3 were not satisfactory. Based on these results, in our current ongoing HD study, radiotherapy was omitted for small parts of patients who had early response during therapy. Also, we intensified the chemotherapy for patients in group 3. Now, challenges and future strategies. After we completed all these studies, we found overall survival rates for patients with lymphoma in China still 10 to 20% lower than rates in developed countries. Here, I list some factors for these results, list some difficulties we met in our clinical study. First, lack of hospital-based cancer registry. For that reason, on one side, some extremely advanced cases at presentation might be underestimated. On the other side, we might miss some cases who abandon treatment during therapy. Second, deficit in the care team. Lack of fully trained pediatric oncologists, particularly in some subspecialty, such as pathology, surgical, radiation providers. For example, limitation in pathology service made us unable to organize central pathological review in our lymphoma study, which is quite important for a lymphoma study. Third, unequal quality of care provided by pediatric cancer center. China is a big country with unbalanced development. Such unbalanced development also exists in the pediatric cancer system. Fourth, drug shortage. Even cheap, widely used drugs such as 6-MP, vincristine, vinblastine, procarbinazine might be unable to get in Chinese market for periods of time. For that reason, we cannot fully copy the treatment from Western country. Last, lack of financial support for multicenter clinical study. Currently, Chinese Science and Technology Committee mainly invest money on basic science research. For that reason, we get into lots of trouble in data collection, interpretation, and long-term follow-up. Even lots of problems or difficulties, we need to move forward. So, future strategies. Unlike the studies conducted in Western countries, our protocol studies do not primarily focus on addressing scientific questions because the feasibility of cure children with lymphoma have been well documented in Western countries. We will continue to adapt well-documented, efficient treatment strategies for use in the conditions present in current China. During the process, we will try to improving the capacity for care, for pediatric cancer care, such as the access to establish some standard treatment protocol for physicians in the rural areas of China, or provide the training opportunity to them. Because currently, our main objective is to prove the outcomes of children with cancer in China. Thank you for attention, and thank you for colleagues in our Lymphoma Study Group.
Thank you, Dr. Gao, and I really liked your talk as it kind of opens again our eyes that cancer care in children is not only dealing about targeted treatments and new biological developments, but also it deals a lot around basic health care for children and support of the health systems everywhere in the world. And I think you have documented that very clearly for your country. Thank you very much. And I just want to open a question that might arise from the audience. So if not, thank you again.